If you're having heart problems, it's important to get a good look inside your heart to see what's going on. Doctors usually do that with a catheter or a thin tube. Cardiac catheterization is done on about 3 million Americans a year to diagnose and treat cardiovascular problems, and the procedure has advanced over the years. Here's more in tonight's Medical Matters. This image is a lifeline to millions of patients a year, and for Walter Kelly, it's going to tell him why he hasn't been feeling like himself lately.
Causes me not to have the strength I ought to and stamina I ought to.
Those problems led him to have a heart catheterization. It's the gold standard in heart imagery and will tell Dr. Stephen Sudi if what's bothering Kelly is a blockage or not.
The word we use is angina, and that means a symptom of poor circulation in your heart. So if your heart's not getting enough oxygen and enough blood, you may have pressure in your chest or a heavy feeling. It's different for different people.
Over the years, the procedure has changed.
Until recently, the typical access site was in the groin. So there's an artery at the top of your leg there that's about as wide as your finger, and we go into the vessel there. And the reason we go there is that artery is close to the skin, and it also is easy to compress.
Today, doctors have an even better method.
We do the whole procedure with this one catheter.
Instead of the groin area, the procedure is done through the wrist or the radial artery.
The artery there is smaller, but you can compress that so easy, so it's very easy to control the bleeding. That most people typically will have two arteries in their wrist, so if there's a problem with this one, you've got this spare one, so it's no risk to your hand that way.
Mr. Kelly, I'm going to let you hold on to this little syringe for me, okay?
Another big difference in the approach is the recovery. With the traditional approach through the groin, a patient has to lie flat on their back without moving for up to 6 hours to reduce the risk of bleeding. If doctors go in through the wrist, a patient can be back on their feet almost right away.
There's just been further refinements in how this is done that have recently made it easier and more feasible to do. Better types of catheters and sheaths and using certain medicines and stuff to make sure that the artery accepts the catheter really well.
11 cc's in there.
Once inside the artery, Dr. Sudi determines if he needs to put in a stent. In Kelly's case, that won't be needed.
It was a very comfortable procedure, very little pain.
He's thankful for that and for what he calls an easy procedure.
Don't be afraid of it, it's not bad at all. More like getting a bee sting or something like that, and that's about it.
I mean, literally, he's telling you you have cancer, and it's much like, you know, the Peanut show, you know, blah, 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 blah. It's hard for you to comprehend it.
It's been almost 2 years since Mitzi Ivy was given a devastating diagnosis.
I started feeling something in my right breast, and then started pursuing it.
Tests soon revealed an aggressive type of breast cancer. She was now in the fight for her life.
So it was very, very shocking.
Shock turned to fear. Mitzi knew the diagnosis meant she could lose her breast. It wasn't until an appointment with Dr. Garrett Peel that her outlook changed.
There's not a woman I've met that doesn't want to try to keep her breast when faced with the horrific news of breast cancer.
Dr. Peel is a surgeon with Previty, a clinic for surgical care in Beaumont. He's one of a few surgeons in the area who perform a groundbreaking surgery in breast cancer treatment. It's very different from the traditional mastectomy where the entire breast is removed, leaving a woman with a flat chest.
Research shows that we can do a skin nipple areolar sparing mastectomy, meaning we make a small incision underneath the breast, remove all of the breast tissue from the skin down to the muscle, just in a traditional mastectomy, and then remove all of the ducts that leads to the nipple. But in this procedure, the woman is able to save her skin, her nipple, and her areolar with a very small incision, with results showing the same as a traditional mastectomy.
Research shows the risk of the cancer reappearing is relatively the same as the traditional method, with added benefits.
This procedure really provides a choice for women to have immediate reconstruction. And our plastic reconstructive colleagues step in as a team approach in the operating room. I do the cancer part of the surgery, and my colleague comes in and puts expanders underneath the muscle. Over time, that muscle is expanded and silicone implants are placed. A lot of women say that I felt like I've just had a breast augmentation, not cancer surgery.
It's been amazing. The outcome has just been wonderful. You know, everyone has said I look so good.
Now, in recovery and doing well, Mitzi is happy to share her story.
I want every woman to know the options that are available for them. I mean, that's the key. Take control. Get that sassy attitude. You know, this is my it's happening to me, but that's okay. Well, it's another bump in the road. I'll get through it, you know, and be comfortable with the choices that you make.
The surgery still allows a patient to receive chemotherapy and radiation treatment. Doctors are calling this surgery a way to treat breast cancer with dignity. Mitzi calls it something else.
To me, it's a blessing. So much of a blessing.
Some women who have not had breast implants feel like if they go in and get breast implants, they're going to look like a quote porn star. You know, I mean, everybody says, you know, and I have them come in all the time and say, God, I don't want to look like a porn star, you know.
That's a common misconception Dr. Mark Larson says many women have about breast augmentation surgery. But in actuality, he says his patients generally fall into 3 categories.
There are women that have small breasts that want to be balanced and have bigger breasts. There are women who had breast who have either through weight loss or pregnancy have lost their volume and want to just regain that volume back. And then the other one is reconstructive.
No matter the type of patient, Dr. Larson says the goal is the same.
The whole key to a good breast augmentation is getting the width that fits. And once you get that width that fits, the cleavage is correct, the height is correct, and the curve is correct.
According to the American Society for Aesthetic Plastic Surgery, breast augmentation was the most performed cosmetic surgery procedure in 2010. Dr. Larson says the ages of patients range from 18 and up, with his oldest patient being 71 years old.
She came in and said, I've been wanting them all my life, and now I'm going to get them.
There are 2 types of implants generally used, saline and silicone. After a recent controversy involving silicone implants, Dr. Larson says they are now safe to use.
One of the things they said years ago was that these implants are permanent. Once you put them in, you don't have to change them out. And you know, the FDA has reapproved silicone implants. The FDA has said silicone's safe, but what they do also say is they need to be changed out every 10 years.
Larson says the selection depends on the patient. There's a variation in the feel of the implant as well as the price.
It was around $4,500 for saline, and it'd be $5,500 for silicone. That's approximate.
There are several methods to perform the surgery. The newest and preferred by Dr. Larson is to place the implant through the underarm.
When we do a transaxillary breast enlargement, this is actually the scope that we use right here. We make a 1-inch incision in the armpit, and you actually take the scope and put it underneath the muscle and slide it underneath there, and then you can make your pocket. And these cameras are really, really high tech. I mean, they really get up close and personal. You can see the weaving in my jacket there.
As with any surgery, there are risks, and some patients are not always happy with the results.
You know, there are some patients out there who, you know, need adjustments on their implants where, you know, one sits higher or lower, or, you know, there's, you know, depending on the forces of the body and the scarring and all, and sometimes those patients will you know, be a little irritated at times just because it'll take a second surgery to fix them, but that's unusual.